All right, everyone, we'll go ahead and get started. I'm sure a few more will join us, but thank you for tuning in today for VCCA's 2021 webinar series, Health in Virginia's Changing Climate. We're very lucky today to have Dr. Sapkota join us, who is a real expert on what we are all seeing outside of our doors and windows, hopefully not too much inside right now, the pollen that is blanketing Virginia and the mid-Atlantic region. So we're very excited. A couple of logistics for the webinar today. One is that all participants are in listen-only mode and will be throughout the presentation. You should feel free to submit questions at any time using the Q&A function, which should be in your Zoom menu. We will take questions at the end of the presentation in the last 15 minutes or so. But please feel free to populate that throughout the presentation as questions occur to you. And with that, I will turn it over to Virginia Clinicians for Climate Action's chair, Dr. Samantha Adut, to introduce our speaker today.
Well, thank you all so much for joining us today for this presentation. I'm really looking forward to. I suspect this is a very relevant topic for many of listeners out there. I know myself in clinic yesterday, I was telling Dr. Sapkota that basically every other patient I saw was for allergies or congestion or sneezing or the like. And so we're really looking forward to hearing from Dr. Sapkota about his research and the work of his team at University of Maryland. Dr. Sapkota is a professor at the Maryland Institute for Applied Environmental Health. He received his Bachelor of Science in Chemistry and Environmental Sciences from Clark University in Worcester, Mass., which I'm proud to be able to say correctly. A PhD in Environmental Health Sciences from Johns Hopkins Bloomberg School of Public Health, and his postdoctoral training in environmental epidemiology from the International Agency for Research on Cancer in Lyon, France. His background is in exposure assessment and environmental epidemiology with a focus on improving the understanding of the impacts of climate change on human health. Dr. Sapkota's research group focuses on the fundamental question of how we adapt to the new threats of climate change, with an overall objective of driving policy to minimize climate change-driven morbidity and mortality at local, national, and global levels. His group is interested in unmasking disparities in climate change-driven health burdens, understanding compound hazards, and developing early warning systems to minimize morbidity and mortality. Through their work, Dr. Sapkota's team strives to inform policy and increase community resilience. For example, in partnership with Maryland Department of Health, his team drafted the first climate and health profile report for the state of Maryland. More recently, his team formed an international consortium to develop an early warning system for diarrheal disease in the Asia-Pacific region. So please join me, everyone, in welcoming Dr. Sapkota to speak to us today.
Thank you, Dr. Adut, for that generous introduction. Let me see if I can share my screen again. I know it was working before. All right. Okay, here we go. So it's great pleasure to be here, obviously talking to you folks who are obviously in the forefront of some of the things that I'm going to be talking about today. So the title of my presentation is Climate Change, Pollen Exposure Dynamics, and Burden of Allergic Diseases. Just a quick outline. So I will talk a little bit about climate change and plant phenology, provide you some background info, and then I will delve into two case studies. First one is looking at association between alteration in plant phenology and hay fever prevalence in the contiguous United States. So that's sort of like the national level data based on, survey. The second is a case study that focuses specifically on Maryland. I think that's the paper that you guys saw, which talks about association between changes in timing of spring onset and asthma hospitalization right here in Maryland. And so hopefully we'll have some time for discussion at the end. Anyway, I expect to go for probably like a half hour or so. That at least that was my directive, and then we'll have a lot of times to discuss. So as you all probably are aware, we as a public health community are sort of like a late arrival in this whole field of climate change. Other field, people in other fields have been talking about it for much longer than public health experts. And if I were to think about it, I think the one thing that changed this was certainly the 2003 European heat waves. And this was absolutely nasty heat waves, where the temperature, at least in parts of France, remained 104, 105 degrees for almost 8-9 days in a row. So absolutely nasty, but what was also kind of interesting about that heat wave is the nighttime temperature, which helps, people to cool down, remain elevated. And I think that's one of the reasons why the mortality was so high on that. So overall, depending upon whose number you believe, it's estimated that this particular heat wave killed anywhere between 50,000 to 75,000 people during that few-week period. And I take this headline from CNN back then. That's alluding to a situation, particularly that arose in France, where bodies were remain unclaimed for days at a time. And France suffered particularly bad during this heat wave for a number of reasons. As you all probably are aware, French are very different than Americans in the sense that they actually believe in vacation. So this heat wave happened at the beginning of August, and August is the month that everyone goes on vacation. In fact, when I was doing my postdoc, my in-laws came to visit us, and my wife and I, decided to take them out to our favorite, French restaurant in Lyon. And it was, Friday in August. And, when we got to the restaurant, they had the sign said, on vacation, come back in September. That never happens in this country, right? So my brother owns a restaurant, like a little bit further away, and he is open basically 364 days out of 365. I talked about this with him, and he can't even imagine, right? So such things simply doesn't happen in the United States. So the reason that I'm saying is, so it was, this heat wave happened beginning of August, and that's when all the young families had gone to south of France or, to the mountains, on their vacation, right? So the elderly relatives, the grandparents, great uncles, and so forth, and they stayed behind on their own apartment in downtown, right? So that's the other difference. Americans love suburbia, but French, they tend to congregate around the city center, right? So I say that because the urban city center tends to be much hotter than your suburban location, even in the same area, because of what we call the urban heat island effect. And the third difference is actually the French do not believe in air conditioning like the way we do, right? So that's the other thing. So remember, this was a heat wave that lasted almost 10 days with a temperature of almost 104, 105 degrees, right? So in the urban city core, probably even higher, right? So that's absolutely nasty. So what ended up happening is when those young family came back from their vacation and went on to visit their relatives, elderly, great uncles, great grandma and grandpa, in some cases they had been dead, and they'd been dead for days, if not weeks at a time. So this sort of like started this whole soul searching in the French society. Then that is, how are we treating the most vulnerable amongst our communities, right? Is this how we want to live? Is this who we are? And since then, many positive things have, come out this disaster, nevertheless. And I think this was also that jolt, that sort of like started everybody's attention in this whole field of climate change, particularly among public health folks. Until then, it certainly wasn't on the forefront of public health, which is not to say that work wasn't happening. There were certainly a lot of, some work happening even before that, but I think this was certainly a major wake-up call. And at that time, this was the hottest temperature recorded in many parts of Europe. But since then, this record has been broken again and again and again. So I was just, you can just see some of those headlines, right? So this is what's happening. But coming closer to home, this animation right here shows you the heat waves in California from 2011 to 2017. And down here, you're looking at different categories of heat wave and the percent area of California covered on that category of heat wave. So the y-axis is percent area covered, x-axis right here is the time. So just to let you know, so this is dark color is exceptional heat wave, exceptional drought. The dark red one is extreme and severe drought and so forth, right? So different categories of drought. So so this is what's happened in California. And while this was happening in California, this is what we encountered. I'm sorry, I don't know what happened here. This is what happened right here in Maryland, right? So you are looking at headlines again from Washington Post, first one, talking about this once in a 1,000-year rainfall event. And I'm not talking about this extreme precipitation happening in different parts of Maryland. I'm talking about all happening right near the BWI area, Ellicott City BWI area, right? So there was a once in a 1,000-year rainfall event in 2014, again in July of 2016, same exact area. Again, May of 2018, same exact area, once in a 1,000-year rainfall event. I get the kick out of those headlines because, if it's happening so often, it's certainly not once in a 1,000-year rainfall event anymore, is it? Right, but I think it goes on to show the situation that we are experiencing, where you have one part of the country, suffering from a massive drought, where in the other part, we are experiencing this torrential downpour. And this is, I think, where things start to get confusing, and your general public starts to wonder, how could we be having both drought and torrential downpour at the same time and blaming both of them on climate change, right? So this is a major challenge. And we have done, I feel, as though a poor job of communicating, right? So whenever there is a vacuum, like this, that presents an opportunity for everyone to jump in, right? And that's where the misinformation starts to flood in. And I would like to bring your attention to one particularly, infamous example where one snowfall event in Washington, D.C. was used as evidence against warming climate, right? So this is perhaps the most infamous snowball toss. Now, whether this is a deliberate effort to muddy the water to create more confusion, or sheer lack of understanding in differences between weather versus climate variability and climate change, that's up to you to decide. But nevertheless, information such as this certainly creates a lot of problem, where then we have our population, our government start to turn away from science. But that's a conversation for a different day. But I do want to bring your attention back to human health. And some of you may have already seen this slide. This is from the recent USGCRP report that's linking different attributes of climate change to human health, right? So you have climate drivers such as increased temperature, precipitation, extreme weather events, and sea level rise. And the exposure pathways are, extreme heat, poor air quality, because air quality, such as when you're talking about ozone, that tends to get worse with the increasing temperature, because ozone is what we call secondary pollutant. It's produced by reaction of volatile organic compounds with the oxides of nitrogen in presence of sunlight and heat, right? So as the temperature goes up, the ozone production goes up too. So that's why you tend to see higher ozone concentration in the Northeast United States, because, obviously summertime temperature goes up. In fact, we don't even bother to monitor ozone during wintertime, because, it's not a concern during wintertime. Then there's certainly changes in infectious agents and population displacement resulting from those extreme precipitation or flooding, and then the health outcome related to those, right? So, but we have to keep it in mind that these things do not happen in vacuum, right? So then there's environmental context, right, that exacerbates this hazard, right? So land use change, ecosystem change, and so forth. But then there's also social and behavioral context that we cannot forget, that drives the vulnerability, factors such as age and gender, race and ethnicity, poverty, right? So if we think about in the context of heat wave alone, who do you think is going to get the heat stroke and die first? It's not going to be folks living in the, those large home with the central AC, right? The first one to go are always people on the street, right? So homeless people. And then after that, it's people living in the homes where the electricity has been shut off because they haven't been able to pay the electric bill, or people living paycheck to paycheck, and so they do have the window unit, but they are afraid to turn it on because they cannot afford to pay the extra electric bill next month, right? So, those are the community that tend to be particularly vulnerable to heat waves. And the other factor comes in, and particularly the pre-existing condition, right? So that also plays a major role. In fact, we have looked at mortality among end-stage renal disease patients, and these are people undergoing dialysis. They cannot cope with the heat just the way you and I do by increasing our liquid intake, right? So drinking more water. So they tend to be a lot more vulnerable. So anyways, so per today's presentation, I'm going to focus a little bit more on the indirect impact of climate change on human health, and show you how the warming temperature leads to changes in plant phenology, and how that contributes to, like the burden of allergic diseases, such as whether it be allergic rhinitis or asthma, right? So first, let's talk about, a little bit about plant phenology. What the heck is plant phenology? So it refers to basically nature's calendar. Right? Just like you and I maintain our own calendar, nature also has its own calendar. Just look outside. We are witnessing the most magnificent transition from, the trees looking almost like dead to now everything starting to bloom, and the leaves turning green and so forth, right? So that's timing of leafing. That's an example of plant phenology. Timing of seed germination, timing of particular flower blooming. When does your tulip bloom? So those are all what we call plant phenology, and growing season length. Obviously, these are highly sensitive to temperature, right? So you probably have noticed when the winter tends to be warmer, we have cherry blossom festival in DC earlier, right? So it's not a rocket science. It turns out that plant phenology are the most sensitive indicator of ecological response to our changing climate. So this is how the ecosystem is responding to the warming temperature, right? So I want to share with you some of the, a couple of data from previous studies done by different groups. And this is a study by Ludziska when he was still at USDA. And this happens to be one of my favorite, paper, among my favorite paper in this particular, and this was certainly influential in me when I was starting to get into this field of climate change and health. So what Lou did is, this is, a natural experiment. So what he did is basically planted ragweed in 3 different locations. So he took ragweed plant and planted them in downtown Baltimore by the Museum of Science. And he planted another set of ragweed plant outside Towson in a county park. That's a suburban location. And he also planted ragweed plant in a rural farm, outside Towson, right? So all of them in this basically the same, greater Baltimore area, and it's the same exact plant, ragweed, right? So he observed them. So he observed them over time to see when they would start producing pollen, right? So on x-axis, you have day, calendar day, okay? So this is January 1 is 1 and December 31st is 365, right? So it represents the exact date, right? So when you compare same ragweed plant that's growing in downtown Baltimore versus rural farm, the plant that was ragweed that was growing in downtown Baltimore was producing pollen a lot earlier, right? If you see right here, versus this is the rural farm, right? And the next thing that was also very interesting was the concentration. So on the y-axis, you have ragweed pollen, grains per cubic meter of air. So what he saw was the same ragweed plant in downtown Baltimore was producing a lot more ragweed pollen. And this is really interesting, right? So what's different between rural farm and downtown Baltimore? Well, downtown Baltimore, by virtue of that urban heat island effect, that concrete jungle is generally a lot warmer, 3-4 degrees warmer than the rural counterpart, right? So that's the first thing. The second thing, downtown Baltimore also has the higher carbon dioxide concentration because of the vehicular exhaust, because of the industry, and because of all the energy, like the home heating and so forth, right? So it tends to have a higher level of carbon dioxide. So that's a harbinger of climate change in a way, so you have warmer temperature and higher CO2 concentration in downtown, and allergenic plants such as ragweed grown on those situations tends to have a longer pollen season and higher pollen concentration, right? So that shows you the implication of it in terms of allergic diseases, right? So very interesting natural experiment. And others have built on this. So this study came out last month in PNAS. It's by William and Rick at Utah. So what they are doing is they took pollen data from 60 pollen monitoring station in North America from 1990 to 2018. So they compiled all those data. And they looked at what's happening to the pollen concentration on each of those stations, as well as seasonality, right? So the top here shows you the pollen changes in pollen concentration over that almost 30-year period, right? So the larger dot represents they have more years of data, right? So more data. And the red color represents a station where the concentration has increased over that 30-year, and the blue color represents station that saw decreases in concentration. So what you see is overall, vast majority of the station, you see increases in pollen concentration during that 30-year time period, right? So this down here looks at the pollen season start dates. When did the pollen season start? Same thing in this case. The red color represents earlier negative deviation, right? So they are starting, the pollen season is starting earlier on those stations. Blue color represents the pollen season is starting later. So again, in vast majority of the station reported pollen season earlier and earlier. It's really interesting data. And they took it also they compare it against temperature, right? So right here, you're looking at temperature on the x-axis. And right here on this first box is the pollen concentration, annual pollen interval. So what you see is, as the temperature increases, you see increases in pollen concentration. And those different color, by the way, represents different regions of of North America. Right, so the trend for each station is also provided within the different color. The one in the middle is showing start date, right? So as the temperature increase, then the gets warmer, and the places where the temperature are warmer report earlier onset of this pollen, right? So which is not surprising, very lean, like nice relationship. And this last one looks at season length. Again, in the warmer area, we see longer pollen season, right? So, very convincing data. And mind you, this is all 60 stations from North America, and the pollen data is, encompasses almost 30 years. So quite a bit of data. So they were able to do this really nice, powerful analysis. And the thing that I really like about this paper is they took it a step further, and they did what we call the attribution studies, right? So attribution source, attribution in terms of anthropogenic climate change contribution. So in other words, what fraction of that concentration is attributable to anthropogenic climate change? Right, so please bear with me on this. So on this first box, you are looking at, again, pollen concentration. The first two boxes shows you annual integral, right? And then the second two set of boxes shows you spring integral, right? So within the first two, like the first box is the whole 30 years of data, and the second part is the more recent 2003 to 2018 data for all of those figures, right? So the second box represents more recent trend. So what we see here is when you are looking at the pollen concentration itself, anywhere from 5 to 10% of those increases in pollen concentration were attributable. They were able to attribute that to anthropogenic climate change, right? So that's what this first box is showing you. The second box is you are looking at actually same analysis, but you're looking at start date, right? So in this case, the attribution is much higher. So in that, almost 50% of the increases in the start date, early onset of start, is attributable in this case to anthropogenic climate change. Remarkable finding. And thus, the last one is same thing for the season length, right? So what's also notable in this finding is that if you look at the more recent data, right, so in all of these cases, you see the anthropogenic climate change attribution higher, right, contributing to the higher level of those changes, which is, what we see in everything else, and what our climate scientists are telling us is that the rate of changes, the warming has accelerated in the most recent decades, obviously, right? So that's what they are seeing with this pollen data too. So really interesting findings. For those of you who are interested, here's the reference. It came out in PNAS just last month. Which brings me to the first case study that I'm going to talk about, which is springtime flowering, phenology, and allergic rhinitis, right? So the question is, do changes in timing of spring onset that are tied to ongoing climate variability and change impact burden of allergic disease, such as allergic rhinitis in this case, right? So obviously rationale, I don't think I need to talk to this group about the importance of allergic diseases. So for this case study, like I said, the outcome is allergic rhinitis, and most recent data suggests that almost 7.5% of US population suffer from it. And it costs US economy almost $11 billion a year, right? So this is just not a matter of sneezing. It does have economic consequences as well. So the data source for this was the National Health Interview Survey data. So this is a CDC survey, annual survey that's conducted by CDC, and it dates back to almost late 1950s, early 1960s actually. Right, so this is a nationally representative sample of US population. So we took a data from 2001 to 2003 for the whole contiguous United States. So we had almost 400,000 respondents, right? So that's our outcome measure. So for the exposure, we were interested in timing of spring onset, right? So how do you go about measuring timing of spring onset? Turns out there's a really great satellite data, because these polar orbiting satellites are going around and around and watching over us. So if you look at this metric called normalized differential vegetation index, or NDVI, this is what it looks like, over Northeast United States, right? The vegetation coverage. And that's a winter time where you have, like most of the tree have lost their leaves. And then it's the same exact location. Now you're looking at springtime, with the changes that we are seeing right now outside, all the vegetation start to turn green, and which is reflected here. And then same thing for summer, the photosynthetic activity increases considerably. So you see like those most intense greenness. And fall senescence hits, and then you start seeing changes in color of leaves, and they ultimately fall, and then you go through the same cycle, right? So if you look at each of the pixel and plot those NDVI data, this is what it looks like. So by looking at the rate of changes on that NDVI, we can actually identify when the onset of spring happened, like in this case, SOS, startup season, right? So that's what it's called. So we are focusing on just this part of the curve, right? So we are interested in, okay, when did the spring onset happen? Right, so we do that for each of the pixel, each of zip code, each of the county, aggregate them, and we average them over that long term, right? So we know on average, this is when the spring onset is supposed to happen in College Park, Maryland. So that's our long-term average. And for each of the year, we calculate deviation. In that, it's giving you, okay, how early or how late what's the SOS on that particular location in that given year compared to the long-term average, right? So that's what we are using. So this is the exposure data is the startup season deviation, and that's derived using the MODIS satellite data, right? So we get those SOS deviation as days, and then we categorize them basically into 5 categories: very early, normal, late, and very late, right? So normal, in our case, we define that as if the spring onset happened 1 week early to 1 week late of that long-term average, right? So if the onset was within that 1 week period, we call it normal. And if it was, greater than 3 weeks early, we call it very early. If it was 1 week to 3 week early, we call it early, and so forth. So we have this SOS deviation data, and we link them with the National Health Interview Survey data, because we know the geo coordinates of those respondents, right? So we know where, what census block they live. So we use GIS to merge those 2 data sets and assign this metric, the changes in timing of spring onset, to each of those interview respondent, and basically do a regression analysis using Sudan, which is a version of SAS that's designed specifically for this National Health Interview Survey data, because it takes into account the complex cluster sample design. So what did we see? So this is basically just the demographic characteristics. So I'm going to skip through it. And let's take a look at this. So this is where we are looking at the, allergic rhinitis. And right here, you see the categories, right? So this is 1 week early to 1 week late is our reference category. So when we compare people living in an area where the onset of spring was very early to those people who are living in an area where the onset of spring was normal, we see almost 14% increases in prevalence of allergic rhinitis, right? And when we compare, people living in an area where the onset of spring was very late, we see similar increases, right? So this was sort of like surprise finding for us. We are not expecting to see this. So this was sort of like, at the beginning, confused us a little bit. And these are all adjusted for other sociodemographic factors. And we also broke this analysis down by different age group, by gender, and by race, and so forth. And no matter what we do, we see this consistent U-shape exposure response curve, right? So this red represents, you know, very early, and the black represents very late, right? So what we see is when the spring arrives very early, we see increases in prevalence of allergic rhinitis. When the spring arrives very late, we see increases in the prevalence of allergic rhinitis. So, that across each of those groups, that you sort of like that U-shape exposure response curve persists. Sort of like, temperature, similar to temperature and mortality, right? So in that very early, very cold temperature kills you, but very hot temperature kills you as well, right? So we like we like to be somewhere in between. So that's what, we are seeing here, a similar analogy. But obviously, there are some limitation of this National Health Interview Survey data. The first one is this is a self-reported measure, right? So it's not doctor diagnosed, right? So it's people reporting, yes, I had those symptoms, because the survey asks you, in the past 12 months, have you had X, Y, and Z, right? So it's a self-reported measure. The outcome is self-reported. And the other challenge, and working with the survey data, is we don't know the timing of symptom onset, right? Because it's asking you, over the past 12 months, have you had this symptom? We don't know if that symptom happened in January, or whether it happened in July or November, right? So because there's no way of finding that, right? So since we are looking at the timing of spring onset, we are not interested in those symptoms, that happened in, for example, in fall or summer or winter time. We're just interested in the springtime. So these were the limitation of this study. So because of this, we did another study now focusing just on Maryland, and in this case, we had very good partnership with the Maryland Department of Health. We are working on the CDC-funded project, and we were able to get the asthma hospitalization data for all 24 counties in Maryland between 2001 and 2013. And for this, as you know, the hospitalization data has an excellent record of, when the patient showed up at the hospital, right, at the ER. So that is very reliable, particularly in the case of asthma, right, because, people get asthma attack, they go to the hospital right away. It's not like they go there 1 day later or 2 days later, right? It doesn't, at least from my understanding, that's not how it works. So we feel very comfortable with this data, particularly when it relates to outcome onset. And in this case, we did the same exact analysis, but the statistical approach had to be a little bit different in that we are now working with count data. So we use a little bit different statistical model, but the exposure was similar. So in all, we had almost 108,000 asthma hospitalization, of which 29,000 happened during the springtime, which is what we are interested in. So when we looked at the changes in timing of spring onset, in this case, each of the patient were assigned exposure based on their, based on their residence, right? So, so we did the similar analysis. So what we see is when the spring onset happened very early, the risk of asthma hospitalization went up, right? And when the spring onset was late, it tend to go up as well. So similar to what we saw with the National Health Interview Survey data. And in this case, we did additional analysis. The first model is just looking at the changes in spring onset, but in the second model, we also adjusted it for extreme heat event and PM 2.5 concentration. In the third model, we did additional adjustment for poverty. So in all cases, what we see is that early onset of spring, in this case, the fully adjusted model, increased asthma hospitalization by 10%. The late onset of spring was, appeared to be a risk factor, but it was not statistically significant, at least in the overall analysis. But when we broke the analysis by further subgroups, the very late onset seems to be a risk factor, particularly among the older groups, like 18 to 64-year-olds, and certainly the older 65-year-old and older. Same thing for African American. I think in the urban area and among African American. So in all cases, what we see is, we were able to reproduce the shape of the exposure response function that I showed you with the survey data. And this is very different in the sense that this is, we're working with asthma hospitalization, right? So much smaller geographic coverage, but the quality of data is much higher. So I think, it was really nice having that consistency between what we observed in the survey data and what we observed with the asthma hospitalization. So as per explanation as to why this may be happening, why do we see higher incidence, asthma hospitalization when the spring onset is early? I think that has obviously to do with the tree pollen exposure during springtime. As you are all aware, the pollen, a pattern in this area is you have tree pollen in spring, you have grass pollen in summer, and you have ragweed, and primarily ragweed in the fall, right? So when the onset of spring is early, your tree starts to bloom early. That means you are getting exposed to pollen early, right? So your pollen season is longer. So that means you have more opportunity to, have those asthma attacks. But when the, spring onset is very late, I think what happens is that, everything gets pushed back, right? So everything gets pushed back and things don't bloom and things don't bloom. And all of a sudden, everything goes gangbuster at the same time. So your pollen season may be much shorter, but the effective concentration in the environment, the pollen concentration may be much higher because all those different species of tree are blooming simultaneously rather than one after another. So this is our hypothesis. And one of my visiting student was looking at it using some of the pollen data we have from Quebec, and is looking at length of pollen season. So, when the spring onset starts very early, we do see like longer pollen season. And I think when the spring onset happens very late, we see shorter pollen season. So basically that summarizes, some of the data that, the second part of the case study. So just to wrap it up, what we see is that early onset of spring increases burden of allergic rhinitis in the United States, as well as asthma hospitalization in Maryland. Right? So that's pretty convincing. So like I said, I think the mechanism driving that relationship is really the length of pollen season, whereas the late onset of spring may be associated with higher prevalence of allergic rhinitis, as well as higher risk of asthma hospitalization among selected subgroup because of, like I said, the higher pollen intensity, albeit on a shorter duration. So I think moving forward, this shows you, the application of this remote sensing data in health community, right? So this is, a lot of the satellite data are becoming more and more available freely, right? So there are a lot more satellites that are out there now. So that means we have a lot more product. Hopefully we will have more and more people using this for not only for epidemiological studies, but also in the clinical settings too, perhaps developing early warning, for example. If we look at pollen monitoring station. The last report from CDC that I read, we have something like 82 pollen monitoring station that is operated by the National Allergy Bureau, right? So 82 pollen monitoring for entire country. And according to that report, it translates into something like one pollen monitor for almost like 3.5–4 million people. Right? If you compare that to the air quality monitoring station, we have thousands, I think something like 10,000 air monitoring station, right? So for air pollution, but for this important risk factor, pollen, for, particularly for asthmatic patient, we just have like less than 100 pollen monitoring station. A lot of them are obviously maintained and operated by folks like you without any support, right? So that makes it extremely challenging. So there's obviously a strong need for perhaps leveraging such satellite data. Now, it's not going to give you exact pollen concentration, but perhaps that's not even the point, right? So maybe even without the exact pollen concentration, knowing when the pollen season starts, knowing when the timing of peak pollen concentration for this tree pollen, for example, happens, I think that sort of information in of itself may be valuable, right? And then as we, as the science matures more, maybe we can get into the pollen concentration. But right now, as far as I know, there isn't any product that's available that gives you the pollen concentration itself. But what we have seen is it is pretty good. It does a pretty good job in terms of determining the pollen season onset, timing of peak pollen concentration, and so forth. So I will stop talking about that, there, and I guess this is where we'll open the floor for questions, and I'll turn the floor over to Dr. Adut.
Yeah, Dr. Sapkota, thank you so much. That was a really interesting presentation, and I really enjoyed it and learned a lot myself. We just a quick reminder to submit any questions you have using the box below. And I will also, this webinar is being recorded, and we will make that available to all of you on our website for clinicians.org. Please feel free to share this with interested colleagues that you think might benefit from this presentation. But I'll go on and highlight just a couple of action opportunities before we open it up for questions. The first being VCCA's call to action on climate, health, and equity for health professionals. Not already, please consider taking just a moment to add your name and support. It's a broad policy recommendations for our state elected officials. To the links between climate and health. Organization, the medical meeting virtually again this year.
Oh, John, we're having some trouble hearing you. John?
My connection
Oh, geez. Yeah, we're having some kind of connectivity issues, John. So I will just, John was mentioning that the Medical Society Consortium annual meeting is coming up, and that's a great opportunity for physicians and clinicians to learn more about this and get more involved. They're really the national leader in medical society engagement on climate and health and influencing policymaking. I was American Academy of Pediatrics, was one of the founding members of that group, and they now represent over half of doctors in the country. So attending that meeting is a great opportunity. Well, before I have a question to get things started, Dr. Sapkota, I'd love to hear from you a little bit about the influence of temperature and air pollution on the effect of late onset spring in your study. I did see that those seem to influence the outcome and how important that was, the extreme heat events on the increase in hospitalizations with later spring?
So I think temperature certainly drives, you know, the spring onset, right? So you know, warmer temperature, you know, earlier onset. So I think they're in the causal pathway in that regard. But you know, when we looked at this specifically the springtime data, and we also look at air pollution, but air pollution was not a factor, and so we did adjust for it, but it was not driving the risk, and that's sort of like expected, because you know, the air pollution generally tends to be a lot worse in the summertime and the winter time, you know, different type of pollutants. But in the springtime, it didn't seem to be as big of a factor, you know, despite the fact that, you know, other studies have shown, yes, air pollution is a big, you know, contributor to asthma exacerbation, right? But in the springtime, perhaps not so much, because a lot of the risk is driven perhaps by pollen in this case. And the temperature also, you know, it's like mild. We have looked at temperature separately in a different study, and during summertime, yes, when there's a, you know, extreme heat event, it certainly drives asthma exacerbation. Certainly the, you know, increases summertime asthma hospitalization during extreme heat event. So, but in this case, I think the springtime, it was not as pronounced.
I see there's a question here from Claudia Brown. Any plans to look further into your hypothesis of a correlation between pollen season onset and season length and pollen counts?
Great to see you, Claudia. Definitely, yeah, I think we are looking into it. And we are, you know, starting some collaboration with Jeremy at University of Washington, and we also have some, you know, data from, you know, additional data from Canada to specifically look into this issue. I think that's going to be really exciting. I'm looking forward to that collaboration. But absolutely, yes, we will be looking into that.
I have another question for you. Anything that you can tell us about changes in pollen composition and changes in potential allergenicity as a result of temperature or carbon dioxide change? I understand there was some early research on that and changes in the actual protein concentration of different plant pollens.
I think the person who did that study is, I don't know, Lou, if you are still here, but Lou Ziska was the one who did it. And I think there was also, you know, a couple of, you know, follow-up study to it. And my understanding is, yeah, yes, it does, you know, makes a difference in the allergenicity of the pollen itself. But I will have to probably like defer to Lou, because he's probably more knowledgeable on that than I am myself.
Well, Dr. Ziska, if you want to type in anything, I don't think you can actually speak in this format. But if you wanted to add anything in the chat, that would be great. Well, before we close out, perhaps you could just tell us a little bit more about your climate and health report for the state of Maryland.
So we actually, the climate and health profile report was the first, you know, step in you know, the CDC grant that we, you know, the state of Maryland received, Maryland Department of Health, and in partnership with them, we did a you know, complete vulnerability assessment. In that, we were interested in knowing, okay, who amongst us are the most vulnerable to the threats of climate change, right? So in that case, we were looking at extreme heat event and extreme precipitation event. So we wanted to identify which area, which of the counties in Maryland, which specific subpopulation in Maryland are most vulnerable to the threats of climate change. And the reason behind that is, you know, in public health, we talk a lot about, you know, responding to those, right? But you can't really do, intervention if you don't know who are most vulnerable to those threats. So that was the first step. So the idea was to identify who amongst us are the most vulnerable. And some really interesting results came from that report, particularly, geographic variability in risk, as well as the racial, ethnic differences. Thing that, stood up, that was something was really remarkable, was the differences in hospitalization for myocardial infarction during extreme heat event, right? So if you look at overall Maryland, I think it was something like 11% increases in risk for hospitalization related to myocardial infarction. But if you break that down by Caucasian versus Black had almost 3 times higher. It was something like 28% increases in risk of hospitalization related to myocardial infarction, whereas amongst white, it was something like 7 or 8%, right? So that sort of, disparity started to come up. And I think that's precisely what we wanted to know, because, that tells us then when there is a heat wave, like who do we go and what community should we target, right? So that sort of information is very helpful in sort of like having your response strategies very, very focused, because that's what we need moving forward as we start thinking about developing this early warning system. So highly recommend for other states to do similar thing. I think a lot of the states are starting to think about it. I know some of the BRACE grantees have already done that, but I think even the non-BRACE grantees, I think it's time to go in that direction.
Absolutely. And Kathy Keller asked if there's a climate and health report in Virginia, and there is not. Virginia, unlike Maryland, has not been a grantee from the Center for Disease Control Climate Ready City and States program, or BRACE program, but they did launch a climate and health committee at the Virginia Department of Health last year that then sort of got sidelined by COVID, but I hope that this will be relaunching. It's so interesting what you're discussing, Dr. Sapkota. We have Dr. Jeremy Hoffman at Science Museum of Virginia has done great research mapping heat, actual temperatures in different regions of this of the state, and found significantly hotter temperatures in the parts of the state that the regions of cities that were historically redlined. And to then be able to extend that to health outcomes would be great.
Yeah.
All right. Any other questions for Dr. Sapkota? Kathy Keller also asked about asthma rates in all counties in Virginia. That I think is available. John, you may be able to correct me through the State of the Air report from the American Lung Association. I believe that's available. All right. Well, thank you again so much for your time, and I've learned so much from your research. I'm so glad you're able to share your expertise with us today. And I would remind everyone that looks like we have a couple more questions real quick here. Oh, nope, we don't. That CME is available for this presentation, and that you'll receive an email tomorrow with instructions on how to obtain CME credit. Well, thank you again. We look forward.
My pleasure. Thank you.
Have a good day, everyone. Bye-bye.